Very good morning, everyone. I'm Dr. Malay Bajpai, Professor and Head Department of Pathology, and today I shall be discussing on the topic etiopathogenesis of tuberculosis. As you know that tuberculosis is a potentially serious bacterial infectious disease that mainly affects the lungs, but it can involve other parts of the body as well. The bacteria that causes tuberculosis are spread when an infected person coughs or sneezes. Most people infected with bacteria that cause tuberculosis don't have symptoms in the initial phases, and when the person gets his immunity gets decreased, he or she can develop substantial symptoms. So when symptoms do occur, they usually include cough, that is could be blood tinge, weight loss, night sweats, and fever. Now coming to the etiology of tuberculosis, it is very important. The most common strain of tuberculosis in humans is caused by Mycobacterium tuberculosis hominis. It is responsible for the most cases of tuberculosis. It is an obligate aerobe, slender, beaded, non-motile, acid-fast bacillus. The basic and very important feature of this bacillus is that it has a waxy cell wall that is composed of mycolic acid, and it has a characteristic feature which is known as acid fastness, which means that they will retain the stains even on treatment with a mixture of acid and alcohol. Now coming to the transmission of tuberculosis, I've already told you before that transmission of tuberculosis is usually by direct, that is by inhalation of airborne organisms which are generated as aerosols and generated by expectoration or by exposure to contaminated secretions of infected individuals. As you can see in this picture, the dot represents the air droplets or nuclei that contain tuberculosis. So it is transmitted from this infected patient to non-infected patient, and it goes, you can see that these droplets are going inside the alveoli or the lungs. Oropharyngeal and intestinal tuberculosis contracted by drinking milk which contains Mycobacterium bovis infection. Although this is rare nowadays because most of the milk that we get in the market is pasteurized, which kills these bacteria. But in rare cases where the tuberculous dairy cows generate milk and it is sold, so there they can develop Mycobacterium bovis infection. So next is Mycobacterium avium complex. It's a very rare disease. Normally this bacterium is killed in the patient who have good immunity. However, in immunocompromised patient like AIDS, they can account for 10 to 30% of patients. Now coming to pathogenesis of tuberculosis, the pathogenesis is centered around the development of cell-mediated immunity, which result in development of tissue hypersensitivity to the tuberculous antigens. The pathological features of tuberculosis is granuloma and cavitation, which is due to destructive tissue hypersensitivity. So the main pathogenesis is cell-mediated immunity followed by tissue destruction. Now the sequence of event from the entry of the bacteria to the lungs and to various alveoli. So first is the mycobacterium. Once they enter the body, they enter inside the macrophages with the help of mannose receptor and complement receptors. So after entering into the macrophages for the first 3 weeks, they replicate inside the macrophages. After 3 weeks of exposure, they reach the draining lymph nodes and are presenting to the CD4 T cells. CD4 T cells produces Th1 subset and are capable of secreting interferon gamma. This T cell mediated macrophage activation and killing of bacteria is basically by interferon gamma, which is released by CD4 T cell, which activates macrophages. Activate macrophages in turn release a variety of mediators. So last step of pathogenesis of tuberculosis is formation of granuloma and tissue damage. Macrophages, which are activated by interferon gamma, they differentiate into epithelioid histiocytes that aggregates to form granuloma. Some epithelioid cell may fuse to form giant cells also. So this whole sequence of event is summarized in this picture. We can see here, this is the mycobacteria, and with the help of these receptors, it enters into the it enters into the alveolar macrophage. So this is a alveolar macrophage, this is a bacteria. We can see with the help of these receptors, the bacteria has entered the alveolar macrophages. So for the first 3 weeks, it stays inside the macrophages and replicates. After 3 weeks, these alveolar macrophages get activated and they produce T helper cell, which in turn produce interferon gamma, which further activates these cells, which result in formation of a granuloma, which is nothing but a collection of epithelioid cells which are modified macrophages along with lymphocytes, and in the center caseous necrosis. This is also due to tissue destruction. Now coming to the types of tuberculosis. So commonly these two types of tuberculosis are known. Primary tuberculosis is a form of disease that develops in a person which is previously unexposed. That means this patient never had exposure of tuberculosis. Secondary tuberculosis is the pattern of disease that arises in a previously sensitized host. That means that this person was previously exposed to the bacteria. Now coming to the morphology, means appearance of tuberculosis. In primary tuberculosis, usually the lower part of the upper lobe is involved or the upper part of the lower lobe can be involved, and normally the lesions that are formed, that is granuloma, they are close to the pleura. Then there is formation of Ghon's focus and Ghon's complex. Next, what is Ghon's focus? This is very important. Inhaled bacilli implant in distant air spaces of the lower part of the upper lobe or the upper part of the lower lobe, usually close to the pleura. After sensitization, 1 to 1.5 centimeter of gray-white consolidation emerges, which is known as Ghon's focus. Now, what is Ghon's complex? Tubercular bacilli, either free or within the phagocyte, drain to the regional lymph node, which enlarge also can caseate. So combination of parenchymal lung lesion and nodal involvement is known as Ghon's focus. To summarize that, Ghon's complex is Ghon's focus, that is the lesion in the lung, along with lymphadenitis, that is involvement of lymph nodes. So Ghon's complex is Ghon's focus plus lymphadenitis. So Ghon's complex was just the parenchymal lesion, and when the lymph node part is also added, it becomes Ghon's complex. So these two are very important things which everyone should know in the pathogenesis of tuberculosis. So this was about primary tuberculosis. Now, what is secondary tuberculosis? I've already told you secondary tuberculosis develops in a person who has been previously exposed to tuberculosis. So initial lesion is usually a small focus of consolidation, less than 2 centimeters diameter or within 1 to 2 centimeter of apical pleura. Such foci are sharply circumscribed, firm grey-white to yellow areas that have a variable amount of central caseation and peripheral fibrosis. In short, we can say this is tubercle with central caseation. Now the tissue changes which occur in tuberculosis. I've already told you that in primary tuberculosis, Ghon's focus and Ghon's complex are seen. So Ghon's focus is nothing but a parenchymal lesion in the lung. When along with Ghon's focus, the lymph nodes are also involved, it is known as Ghon's complex. In secondary tuberculosis, along with this, there is formation of large fibrosis and cavity. So sometimes the MCQ is asked, what is in which type of tuberculosis cavitating lesions are seen? So it is secondary tuberculosis. So I will show you some pictures to tell you about Ghon's focus and Ghon's complex. We can see in this picture, this is a piece of lung, and you can see this is pleura, and here we can see some lesion just below the pleura. So this is nothing but a Ghon's focus, which I've already told you, it's a parenchymal lesion which is present just below the pleura. So commonly seen in primary tuberculosis. So this was about Ghon's focus. I've already told you that in secondary tuberculosis, usually there is formation of fibrosis and cavitary lesion. So important features of secondary tuberculosis are necrosis, fibrosis, cavitation, T cell response, CD4 enhance killing, CD8 kill infected cell, giving rise to necrosis. So you can see this is a section of lung. This is the apex of the lung, this is base, and in the apex of lung you can see this empty area. This is nothing but a formation of cavity in the apex of lung, and here also there is one lesion which is in the process of formation of cavity. So some yellow areas can be seen. This is nothing but necrosis. So basically tissue destruction is the main feature of secondary tuberculosis. In primary tuberculosis there is hypersensitivity and cell-mediated immunity in formation of Ghon's focus and Ghon's complex. In secondary tuberculosis, advancement of tissue hypersensitivity which leads to necrosis, fibrosis and cavitation. So this is very nicely represented in this picture. So this was about the gross examination. Now we'll see how a picture of tuberculosis looks inside a microscope. So in this picture different powers are seen. This is the low power view. You can see that this is a section from the Ghon's focus which I showed you in last two slides. Here you can see this pink thing in the center is nothing but necrosis. Here we can vaguely make out some giant cells are seen. So giant cell, I've already told you, giant cell is nothing but a collection of epithelioid cells which fuse and forms a very large cell. So in high power we can clearly see this is a giant cell which has more than 50 nucleus and a U-shaped nuclear pattern, that they are known as Langerhans type of giant cell which are specific to tuberculosis. Here we can see some epithelioid like cell, and this is necrosis. So this is very commonly asked question in Viva, what is granuloma? So granuloma is nothing but a tiny lesion which is comprised mainly of epithelioid cell along with central caseation necrosis and giant cell, and which is further surrounded by lymphocyte. So if we go from inside to outside, we can see here a lot of caseation necrosis which appears pink here, pink and homogeneous. Then here we can see some epithelioid like cells, and then here we can see Langerhans giant cell, 3 Langerhans giant cells are seen, which is further surrounded by fibrous tissue and many lymphocytes and hemorrhagic tissue. So another picture with an enlarged view, we can see these are our epithelioid cell. They are nothing but slipper shape. They have slipper shape, vesicular, clear kind of nuclei and eosinophilic cytoplasm. We can see many epithelioid cells can be seen here. These are all epithelioid cells, and this is nothing but a Langerhans type of giant cell, around 20 to 30 nucleus and a large cell. These are all lymphocytes, dark round blue in color. These are all lymphocytes. So this picture shows tubercular bacilli. This is a AFB stain in which the tubercular bacilli appears pink or purple. Now coming to the different picture, this is a quite better picture here. We can see again this is a granuloma. It does not have a necrosis. So here we can see this is a giant cell. These are lung alveoli. These are normal lung alveoli in which we have a granuloma. This is a giant cell. Again, this is a giant cell. Certain epithelioid cells are also present here, and it is surrounded by fibrous tissue and lymphocyte. So granulomas also can be caseating and non-caseating. In the initial stages, caseous necrosis do not develop. In later stages, when there is marked tissue destruction, so caseation can occur. So this is non-caseating tubercular granuloma, which shows Langerhans type of giant cell, epithelioid cell, lymphocyte and fibrous tissue. In the right side picture, we can clearly see this is necrosis. Pink homogeneous material, caseous necrosis, which is surrounded with many epithelioid cell with this slipper shaped nuclei. So again, this is granulomatous inflammation with caseous necrosis. This is a picture showing TB lymph node. I've already told you Ghon's complex is combination of Ghon's focus, that is a lesion in the lung, along with involvement of draining lymph node. So this is again a section of lung. This is the hilum where the branches of bronchus are present, and at the hilum we can see yellowish color round structure. This is nothing but lymph node which has undergone caseous necrosis. So caseous necrosis is the name given to cheese-like appearance. So you can see this is yellow cheese-like appearance. That's why the name cheesy necrosis or caseous necrosis. So gross specimens show matted lymph node and cut surface show yellow caseous necrosis. So at the last, I want to show you the how do we do staining. Normally we do a ZN stain for which we'll be reading more about in microbiology. We use acid fast stain. In the beginning of it, I've already told you that this has cell wall has mycolic acid which resists to acid fastness. So we use a acid fast or Ziehl-Neelsen stain in which the bacilli appear slender, rod shaped and pink or pink color. So you can see background shows a lot of necrosis, and in this many bacilli, rod shaped bacilli are seen. So Mycobacterium tuberculosis in a sputum. So this is a sample from a sputum. Acid fast stain is diagnostic of mycobacteria.